Welcome to Credentially's podcast, your HR healthcare kit.
Hi there, how are you?
Good, Megan. How are you?
Doing good.
Excellent. Well, thank you so much for joining me. I'm here today with our guest, Megan Maygra. Megan is a nursing professional development specialist. She's also the founder of Spruce Nurse Consulting. She has over 2 decades of healthcare experience and also works for PeaceHealth, a really large not-for-profit Catholic healthcare provider that's working in Washington, Oregon, and Alaska. So you've had a really interesting career. I'd love to hear how you started working in healthcare and how you got to where you are today.
Yeah, so I actually started as going towards my paramedic degree and started at the spring quarter of my senior year of high school, going to college, and then that first summer got my EMT and then got into the paramedic program in the fall of 2001. And we all know what happened September 11th of 2001. And those events actually changed my outlook on my career. And I decided to quit my paramedic program at the end of my semester and join the US Navy to go be a hospital corpsman. And I told them that I absolutely wanted to end my first semester of my paramedic program and absolutely had to be into the medical field. And at that time, they couldn't offer me a position. And so they offered me a guaranteed school after I went out to the fleet for some time. So I did that. And while I was out on the fleet, I got my school that they had guaranteed. It did some training while I was in that program. They asked if there were any fleet returnees and if they wanted to go to surgical tech school. And so because I had been out to the fleet, I got the opportunity to go to surgical tech school. And kind of that's how my operating room experience started, was based on that situation in the Navy. And I then transitioned to, I practiced for 2 years in the military, and then went to a isolated duty station called Diego Garcia. And while I was there, I wasn't able to practice in the operating room because there was no operating room. And so I did more of that emergency medicine type of stuff, and really just kind of learned a broader perspective of medicine. And had an encounter with one particular patient that kind of made me go more towards the nursing route versus the physician route that I originally wanted to do, because that's why I was going to go to paramedic school, was so I could pay for med school and become a surgeon. And so based on that experience I had with that patient and them coming back in for that follow-up care, I decided that being a physician wasn't my route and I wanted to really go do the nursing thing. So when I got out of the Navy, I went and got into nursing school. And I've just continued to find my way progressing in my career, and have done some management, and currently in the clinical education realm, working on a system level and not just for one particular unit anymore. As well as you had mentioned, I just recently launched my own consulting business that has had a little bit of a challenge trying to get launched, but it's been fun nonetheless. And I'm really excited about what the future will bring for being able to share my wealth of knowledge with others.
Yeah, no doubt. I'd love to hear more about that encounter with a patient that sort of, made you realize that nursing was the vocation for you. Can you share anything about that?
Yeah, so he was like a 35-year-old African-American male who came in really bad diabetic ketoacidosis. Now, being on this isolated duty station, there was not really a critical care aspect that we had. It was actually a clinic staffed by about 40 medical personnel. We had the capability to do 2 up to 4 inpatients at a time. But it really was not a spot where we could truly take care of patients long-term or really critical ones. And we ended up medevacing them, the very critical patients out, or those that needed surgical services, we had to medevac them out to either Singapore or Africa, or sometimes back to the States if they could allow, if they were a military person. It just kind of depended on their medical needs that they needed. This gentleman, though, came in pretty sick, and we admitted him. And I remember just thinking, he is my patient, and I am going to stay up with him all night long, because I was on duty that day. And so I literally sat next to his bed all night long. I remember that the TV was on. We were watching the movie Madagascar, the cartoon, and he was sitting, laying in the bed next to me. And I was a hospital corpsman. I didn't have a nursing background. I had very basic medical knowledge. And it was my job to assess this patient, yet I really didn't know what an assessment looked like. And so I was really more afraid of my own competency, or my lack of competency, than I was for kind of how he was. And I mean, we made it through the night. After a few days, he did get better and got discharged from our clinic. And he would come back for his follow-up care probably like a month or two later. And I saw him as I was just randomly walking through the clinic, and he was like, "Hey, I remember you. Thank you so much for taking care of me that night." And he was just so appreciative and asked me how I was doing. And to me, it was that connection with that patient that I was like, this is what I want. This is what I need to do. I want to take care of people, and I want them to feel better. And I want them to know that I did a good job, even if it was very scary for me, because I didn't feel like I had the competence. And so that has kind of forced me more into I don't ever want a caregiver to have to feel that same feeling that I had that night. And I don't ever want a patient to have to potentially experience someone's incompetence, because even though I was very scared inside and I felt that I didn't have the competence, I did not show it to that patient, and he did not recognize it. So that's kind of the moral of the story, is just really making sure that we don't really show our fears, and that we just keep asking those questions and going ahead with what we need to know and do, and escalating issues if they are very uncomfortable according to our competence levels.
Yeah, I certainly remember experiencing the same thing. When you start emergency medicine practice, you kind of get thrown at the deep end. You pick up a card that has a patient summary on it of their initial assessment, and you think this could literally be anything, and you pull back the curtain and you see what you find. And yeah, I remember kind of sharing those nerves. But it sounds like a moving experience, so that's really nice. And I like the way that it's transitioned you into what you're doing now. And I think making sure people develop well in their careers, making sure that they're adequately supported and trained and retained by organizations has similar elements, right, of that kind of consistent care and that continued care, rather than just you do something once for someone, like you get them employed and then you sort of forget about them forever. It is more of a continued relationship. So I'd love to hear from your point of view what you think the biggest challenges are for providers right now that you see with regard to kind of their workforce, whether it's attracting new people, retaining the ones they have. What are you seeing on the ground?
I think the biggest thing right now with post-pandemic is just caregiver burnout.
Yeah.
Is everyone is just to the top of what they have been able to give. And it's a challenge because, there's a great resignation that's going on, and people of all areas are transitioning their careers or reducing their hours or really making a change at such a higher rate than what we've ever seen before. And our new nurses coming out of nursing school don't have the same training that our past nurses have had, because the pandemic prevented them going into getting that hands-on care. And I actually did take on a semester of students last winter, and it was my first time teaching nursing students, and I was teaching them virtually. It was a huge challenge to try and teach people who've never had these experiences something that you really need your hands on for.
Yeah.
And so, our teaching style has had to change and adapt. And then our onboarding style of these new grads has had to change and adapt based on just what the pandemic brought forward to us. And some facilities are still struggling on, how do we get these students into our areas for clinical placement when our nurses are so burned out and we're short staffed, and we just don't have that capacity to do more. But it's a critical piece, because if we take any of those pieces out, we're going to implode our healthcare system, which I feel like we're already starting to see some of those effects, and we're just kind of barely above the water at this point. So it really is a full circle of what healthcare systems need to do as far as getting students in, training them, and then when you hire new grads, bringing them on board, and what does that look like? Because we're going to have to put more effort into them at this point, with not having that hands-on experience from the pandemic issues that arose. So it's a really critical time for looking at onboarding competencies, especially of new grads.
Yeah, that's really interesting. I sort of hadn't realized, but of course, with everything, with the sort of work from home, or stay in place, or sort of however you want to call it, movement restrictions during the pandemic, it's obvious how it's affected other industries. But I sort of hadn't imagined that nurses or student nurses would be prevented from sort of going into those places and getting that experience, right? And I remember being a medical student, and even when you have that hands-on experience, you're trying to learn on a human, it's still really difficult. The first few times you try and take blood or put in a cannula or catheterize someone, or what have you, after having done it many times on a mannequin. But to try and learn a lot of those hands-on skills over Zoom, not even with real people, is a really tall order. So I can see why that's a concern, making sure those people are supported and they can get those hands-on experiences, because, as you say, it is a big drain of resources to train people, right? It's completely necessary. And if we don't do it, we just don't have the next generation of medical professionals, especially as this, generation are retiring sooner than had been the case. It's something that we're seeing globally. And the great resignation, as you said, or just changing careers, right? Because they're burnt out, they're traumatized in some cases, they've been working very hard, and they need a change. So I see what you're saying. There's sort of, the two pressures, and there's the worry that if we don't sort of adapt now, we could end up with things getting dramatically worse in a few years, where there's just no one to pick up the baton and treat the patients and train the next lot of graduates. There's just not enough slack in the system.
And the other thing that we have to consider is, COVID's here to stay. And, are we going to get more surges? We don't know. Are we going to get a surge of monkeypox? Because that's the new pandemic going around. Is the flu going to be changed so much because it wasn't circulating like it has in the past, because people were masked because of COVID? And so there's a lot of kind of unknowns on, just from a disease aspect, on what could be happening, not to mention the pandemic we have going on with just mental health right now. And people with depression and suicide and anxiety and just all of that. I mean, we're really in a difficult situation with our mental and physical health with everyone. And it's not just one population, it's really a worldwide issue that we have going on. And the mental health aspect is kind of what's driving a lot of this, because people are really reevaluating what they want to do in life. And I don't think there's anything wrong with that. I actually think it's a really great thing, but it's a trickle down effect. And so everyone has to kind of look at the full picture of what are we going to do? Not to mention, we have all this bully behavior that's gone on. And is that increasing, even though we're getting more knowledge out there about it and trying to prevent it and everything? I mean, I think that time will tell on that, but I think that's a huge issue as well, is to, just look at how we're treating one another. And that can go along with your retention rates. If you're not treating a new grad okay, then they're going to leave. I mean, that's something that we really have to consider. And we have generational differences, which I think those have definitely gotten better and people are more educated on that. But there's a lot of factors that play into just retention of healthcare providers. Plus, our patients are sicker. That's kind of the other thing, is that people are seeing things at a more worse state than what they've ever seen before.
Yeah, we're seeing the same in the UK. People are presenting later, and often they haven't been able to get sort of non-emergency care because of the things that were rescheduled or delayed during the pandemic. So they've gotten sicker with, their mobility, their heart condition that they need a pacemaker for, whatever it was. And so they've had sort of not just the effect of that on their mental health, on their sort of activities of daily living, on their family, but also then the health service has to deal with those people, plus all of the other problems that they've developed either as a result or just incidentally. So yeah, the patients are sicker, the staff are more tired and burnt out in some cases, and there are real issues now, certainly in the UK, but we hear this from everyone we talk to everywhere, about sort of retaining those staff that in some ways have more options than ever. And we're seeing a lot of healthcare professionals move into the technology field, which I can't criticize anyone for, because I suppose that's what I've done. But into other sectors where they're not maybe treating patients full time, and as a result, their lives are a bit more manageable in some cases. We still have those patients, right, more than ever, and sicker than they have been. So it's a difficult time for the health system. I think we've covered lots of bad things. I'm keen to hear if you have seen any sort of green shoots, or if you've seen any things that make you think, oh, okay, maybe there is hope, whether it's sort of, I don't know, new technologies or new ways of working. What sort of got you thinking positively at the moment, if there is anything?
Well, I think just, with people realizing that COVID's here to stay, we've been able to kind of get back on track with our strategic goals and start moving towards some of those things that were put on hold. So I think that's a real positive thing, is that, okay, we've, sat here for 2 years, like putting everything on hold, kind of a start-stop type of situation. But now we got to the point where we can really dissect these things and kind of look at how COVID changed, how we should maybe do some things, or maybe we need to incorporate things a little bit differently because of COVID. And so I think that's a positive for what we should be doing, as well as, just looking at these new grads, like, okay, we can recognize that they didn't have the hands-on training, but maybe we weren't giving them enough to begin with. Maybe we should have tailored their orientation a little bit differently from this, even before the pandemic. So I think it's just a good way to look at things in a different perspective, to move forward and make things a little bit more streamlined and a little bit better. Not to mention, going back to that mental health of like, well, we understand people are stressed out. And so do we need to start bringing in additional resources for that? And what is out there? And so I really think there's a bigger focus on that work-life balance and that mental health care of our caregivers. And the facility that I previously worked for, they actually offered chaplain services to come up when there were things not going well on a unit for the caregivers. So maybe you just got yelled at by a patient. Maybe there was one of your colleagues had a significant death in the family. Maybe someone's going through a divorce, anything like that. And so our chaplain services, which we usually think are there for our patients and their families, they're actually there for us. And so they created a what they call a code lavender. And what happens is that chaplain services comes up with a little care package and, some inspirational words and, just some time to talk. And so I think that's a really positive thing, that, here's an in-house resource that we can actually have in a moment's notice when things aren't going well. And that was never really there before.
No, I mean, that's amazing, right? It's sort of an emergency service, if you like, for people's kind of occupational health, occupational mental health. And
right.
That sounds like a really wonderful thing. I remember working my first job, I worked at a hospital that had a really great chaplain called Jim, who would come around and talk to patients, particularly when I was working on the care for the elderly rotation. And but he'd sort of have reassuring words for everybody that needed them. And I've seen a lot of people, really great practitioners, often working in medical and nursing fields, get burnt out or feel the stresses of their job, particularly, I have to say, when they've had a difficult interaction with their colleague or boss. Often I've found from my own experience and watching others, it's those experiences with our peers often, or with sort of, the people that are training us, that are kind of most stressful. Even though, I've been attacked by patients working in A&E, and I've seen colleagues attacked, often by people that, don't know where they are or what's going on.
Right.
But it was often those bruising telephone conversations you'd see people have when they're trying to get another specialty to come and help, that really upset people the most, rather than even in some cases physical violence. So is that something you've experienced, sort of clinicians getting stressed because of difficulties they're having with kind of their peers or colleagues?
Yeah, absolutely. I have had plenty of opportunities to experience that unfortunateness. My specialty is in the operating room, and unfortunately, the operating room is well known for some of the bully behavior that happens, and the some of the comments that are made, and just the ranks roles in the operating room are very different. And so that has been a huge aspect of just turnover, specifically in the perioperative world, being yelled at by surgeons or anesthesiologists or techs or nurses or whoever is working there. And I understand the reason why. I mean, it's a very high stress environment. You're cutting somebody open. You make a wrong cut and you can kill them instantly. And so it's a very identifiable reasoning. However, it's not okay to do.
Yeah.
And so, having some of those experiences, I would say my worst ones were probably peer-to-peer, lateral violence that occurred. And I think the reason caregivers have more angst about that is because you have to work with those people. You have to come back and see them. Whereas if it's a patient that attacks you verbally or physically, they're gone after they discharge. So it's not as big of a deal. And yes, I have been assaulted by patients. And it is, it is a very scary feeling.
Yeah.
And it's hard to get mad at the patient, especially in the operating room, because they're under all these drugs that affect them cognitively. And so you kind of blame it on that versus actual intent and bad behavior that they want to harm you. But it's still very scary regardless of if there's drugs on board or not. But I knew that once the patient was in the PACU, it wasn't my problem anymore. It was somebody else's problem, and I'm probably never going to have to see that patient again. However, when I have my peer doing it, I have to work directly with them. They're going around talking to other people that I work with about me, and it just continues on and on. And it's a really unfortunate thing that occurs. And unfortunately, nurses are known to eat their young. And so a lot of times it's that higher, or I should say the more experienced nurses onto the younger nurses, because they don't know what they're doing. The experienced nurses in this patient, I mean, we could list this stuff out all day long, but the bottom line is that we are all equal. We are all there for the patient, and that's what matters the most. And we need to take care of each other physically and mentally, as well as with competence. If I don't know how to do something and I'm coming to ask you for help, you need to come help me. That is your obligation as a nurse, to make sure that we as a team take care of this patient. That's kind of where I stand with that.
Yeah. Wow. I mean, I've never heard that nurses eat their young.
Yeah.
I like that expression, but I would never dare say it to a nurse, because as a good doctor should be, I'm quite scared of nurses. Whilst I love working with them, and I've benefited greatly as of my patients, but I wouldn't like to cross one. But that's a really interesting perspective. And I agree. I think people do need to feel that they're supported and know that there's people they can turn to when they do feel most unsure and most afraid, and not get yelled at, but get supported. Because where they don't have that, or they have the opposite of that. They think, I need to keep this a secret, that I don't feel like I know what I'm doing, or I need to hide the fact that I've made this mistake. That's when things can get really bad. So yeah, I agree with you that that culture is very important. I remember when I started practice, the operating theatres that I would go to on my surgical rotation had posters in them saying, bullying is not acceptable here, like bullying will not be tolerated, and sort of pictures of people yelling at other people. And yeah, that was, you know, back in 2011. So I think it's been recognised. There's been problematic culture, certainly in healthcare in the UK for a while. I'm glad that there is more recognition, but I think, yeah, we need to ensure that that's being fixed. I'd like to talk to you about sort of Spruce Nurse Consulting and what led you to set that up, and kind of what are the queries and issues that people are coming to you for, looking for help with.
Yeah, well, it is a new company. I just launched it in January, and unfortunately, it's been a very busy year. I actually transitioned into a new role within PeaceHealth just in July. And so trying to just navigate some of that with trying to run a business has been quite a challenge. So I haven't gotten it really up and running as much as I want, but some of the things that I've been consulted on are on legal nurse consulting for one. So just kind of helping the legal field on how to navigate some of the nursing concerns that occur in like personal injury cases and stuff like that. And then just even for my colleagues, just, you know, resume review and how do you do interviewing skills for these type of roles. And really, if you're trying to get into that leadership role, how do you make that transition from being a staff nurse to a leadership type of position? As well as I did my very first conference for the Oregon Association of Surgical Technology. And actually my topic that I discussed was on teamwork and kind of the roles in the operating room and bully behavior and all that. And so that was really fun to do that and present the information to a group that really they don't get a lot of this type of focus, because a lot of this stuff goes to physicians and nurses, and it doesn't go to our ancillary roles that are a critical part of our healthcare team. And so it was really fun to be able to have that discussion with that group and just kind of highlight the important things that are really being discussed from that leadership level, but never really make it down to that front line level. And so that's kind of some of the stuff. My goals are really to look at some just strategic planning for organizations and what they can do to kind of either better their education plan.
Megan, I'd like to thank you very much for talking to me today. I've really enjoyed our conversation. I think there's lots of good themes there about culture, about the importance of training the next generation of clinicians. I really was scared by, but appreciated your perspective on sort of the real challenges we face because of the disruption of medical education during COVID. And it was really interesting to hear a bit about your career and the things that led you to know that nursing was your vocation. So on behalf of myself, Credentially, and our audience, I'd like to thank you very much for taking the time today.
Thank you. I really enjoyed this, and I wish everyone well. And we'll get through this and become stronger and better people because of everything that we've gone through the last few years.
Fantastic. Well, spoken like a true hero. Thank you very much, Megan. And I hope you have a great rest of the day.
All right. Thanks. You too.
Take care.
All right. Bye-bye.
Search Credentially for your current healthcare staffing insights.